Hello everyone. In this edition of Common Encounters in Cardiac Care, we will be going through what's the deal with Lp(a) or lipoprotein A. In recent years, there has been a great deal of interest in Lp(a). Beyond the traditional risk factors of smoking, hypertension, diabetes, and obesity, Lp(a) has now been established as a risk factor for various cardiovascular conditions. Lp(a) is essentially a low-density lipoprotein particle which is attached to the apolipoprotein A molecule. The key significance of this is that Lp(a) is considered to be more prothrombotic, more atherogenic, and more pro-inflammatory than your typical LDL particle. It is thought that 1 in 5 people worldwide have elevated Lp(a) levels, and about 70 to 90% of it is genetically determined. However, various medical conditions such as diabetes, chronic kidney disease, as well as postmenopausal state can also contribute to elevated Lp(a) levels. As is seen in this graphic, elevated Lp(a) is associated with a whole host of increased cardiovascular events, and these are increases in risk of acute myocardial infarctions, cardiovascular mortality, progression of aortic valve stenosis, stroke, as well as peripheral arterial disease. This graph depicts the linear relationship between increasing levels of lipoprotein A concentration and increase in cardiovascular disease risk. The threshold for high cardiac risk is 50 mg per deciliter or 125 nanomoles per liter. So when should I order Lp(a) for my patients? The European Society of Cardiology guidelines recommend all adults to be screened at least once in their lifetime, and the American College of Cardiology recommends screening in patients with premature coronary artery disease if not explained by any other factors or a family history of premature coronary artery disease. So how should I manage my patients with elevated levels? First off, it is important to note that statins do not lower Lp(a) levels. PCSK9 inhibitors has been shown to modestly lower levels by about 25 to 30%. Several therapies are currently in development to target Lp(a) specifically, and we await the outcomes of these trials. Currently, management should take into account absolute global cardiovascular risk, and all risk factors should be comprehensively addressed as per guideline recommendations. Also, do consider cascade screening of first-degree relatives in patients with a family history of elevated Lp(a). Thank you very much.